All right, Miss Penny, what is the function of your thyroid gland?
Your thyroid excretes hormones.
What are those hormones? Very good.
T3 and T4.
What's the third one?
I don't remember.
TSH.
TSH would be from the anterior pituitary gland, which controls the thyroid gland. There's a third hormone. What was that?
Calcitonin.
Sorry again?
Calcitonin.
Very good, calcitonin. The other calcitonin lowers calcium levels, whereas the parathyroid hormone, which is secreted by the parathyroid hormones attached to the thyroid gland, raises calcium levels. Right? So we have two glands acting doing opposite functions. So whenever your calcium levels are low, then the parathyroid hormones will be released by the parathyroid glands. And when your calcium levels are too high, then the calcitonin will be released by the thyroid hormones, lowering the calcium levels. All right, but let's begin with the thyroid hormone. Yes, thyroid hormones first. We only have two possible problems. This is endocrine. So let's start with hypothyroidism, and then this will be followed by hyperthyroidism. Now, there are two forms here. We have a primary hypothyroidism, which affects the thyroid glands, meaning the problem in chapter 43 is talking about a primary disorder of the thyroid gland, because there can be a secondary, which is caused by a pituitary problem. So it works like this. We have a master gland, which is the pituitary gland, which can fail. There's also a disorder affecting the pituitary glands. It can be hyperpituitarism, or it could also be hypopituitarism. Now, since the pituitary gland controls most other glands, namely the just to name two are the thyroid glands and the adrenal glands. We'll cover adrenal problems next semester. So in the case of hypopituitarism, for instance, meaning there is an underactivity of the pituitary gland, and since it controls the thyroid glands, therefore a hypoactivity of the pituitary gland will lead to a secondary hypothyroidism. Does that make sense? So it works like this. Whiteboard for never mind. Let's try a Word document. Can't do that. Never mind. This is my son's computer. I don't have a whiteboard here. Okay, so if you have a hypopituitary activity, and since the pituitary gland secretes TSH, thyroid stimulating hormone, if there is low TSH, will there be enough stimulation for the thyroid glands to produce T3, T4? Yes or no?
No.
No. So therefore, that can result in hypothyroidism. All right. But in that case, in that instance, in that example I am giving you, that is only a secondary hypothyroidism. The reason is there's really nothing wrong with the thyroid gland in that instance. Because in that example, it was the pituitary that is defective. The pituitary gland is not releasing enough TSH or enough thyroid stimulating hormone. Therefore, it caused the hypothyroidism. Are you with me so far?
Yes.
Okay, so this is what that first statement says. Okay, there can be a secondary type of hypothyroidism. And in that secondary type, there's nothing wrong with the thyroid gland. The problem lies with the anterior pituitary gland, which is in that example secreting not enough TSH, meaning if your TSH is low, in that instance, meaning it is the pituitary gland that is not secreting enough TSH, therefore there is not enough stimulation of the thyroid gland, leading to hypothyroidism. Any other question on that? So we can go on. Is that clear enough?
Yes.
Okay, so in case you get that question either on my exam or on the NCLEX, so those are two separate problems there, because a pituitary problem can lead to either hypothyroidism or hyperthyroidism, okay, depending on the activity of the anterior pituitary gland. So by contrast, if the anterior pituitary gland also releases too much TSH, then that will lead to hyperthyroidism. Okay. All right, so let's move on to the primary disorder now. So in primary hypothyroidism, meaning the problem here is the thyroid gland itself. The causes of primary hypothyroidism are the following: Hashimoto's thyroiditis, which is an autoimmune disease, which is the most common. And we have thyroid surgery, meaning you had hyperthyroidism and then you had surgery to treat it. Then you become hypothyroid. So either the the thyroid gland, the primary hyperthyroidism was treated either by surgery or radiation, results in the death of the thyroid gland, leading to um, hypothyroidism, right? Meaning the treatment for one here, specifically with hyperthyroidism, might lead to hypothyroidism. And then vice versa, treatment for hypothyroidism may potentially lead to hyperthyroidism. So if table 43-1 makes sense, so this is what I was talking about. The problem can stem from the anterior pituitary, not always from the thyroid glands themselves. For the exam, I'll be using table 43-2 for the levels. So we have free T3 and then free T4 and then TSH. Okay, just these three. free T3, free T4, and the TSH. Is that clear? Hello?
Yeah.
All right. Let me explain this chart because this is the reverse. So for primary hypothyroidism, meaning that this is a problem with the thyroid glands themselves. Nothing's wrong with the anterior pituitary. All right. So look at the value of TSH in primary hypothyroidism, meaning the problem here is the the thyroid glands themselves. Why is the TSH high? Whereas it is low in secondary. Any volunteers?
Because
Miss
in primary, it's not an issue with the parathyroid releasing
in the
the
thyroid.
no in primary hypothyroidism, isn't it? The thyroid stimulating hormone is still being released. The thyroid is just not responding to it. And then in secondary, it's the fact that the thyroid stimulating hormone isn't being released. So that's why.
All right, very good. So in primary hypothyroidism, since the problem lies with the thyroid glands themselves, nothing's wrong with the pituitary. So because in primary, the thyroid glands are defective, therefore they're not releasing T3, T4, that low T3, T4 level, which is here, low, 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 this will become the trigger for the pituitary gland to release more TSH in order to increase in an effort to increase T3, T4 levels. Are you with me so far? So therefore, just like what was said earlier, because it's a problem with the thyroid glands, not a pituitary problem, therefore there will be increased levels of TSH in order to stimulate the thyroid glands to release it. However, because the thyroid glands themselves has a problem, no matter how high the TSH is, the thyroid glands just simply cannot release T3, T4. Whereas in the pituitary problem, which is secondary hypothyroidism, there's nothing wrong with the thyroid gland. They just didn't receive any TSH, or I should say, there's not enough TSH in order for them to produce enough T3, T4 because of a pituitary problem. Any question between primary and secondary?
Professor, I've seen a couple patients with like low TSH level, but then normal T3 and T4. Like, how would you categorize that type of situation?
Those people may be receiving hormone replacement, but that would still be what is this? What was the patient's problem? Is that primary or secondary?
I don't know. Like, I just sometimes I see patients on their screening, like they're not on any medications, but like on their screening physical exam, we only test for the TSH, and it was like abnormally high, and then we do the workup for the T3, T4, and it's normal. So I don't know.
Normal or low?
Normal for T3 and T4, but abnormal for TSH.
Oh, okay. In that instance, as long as the numbers stay, because
Obviously it's not outrageously
right,
abnormal. No.
yeah. So that could be that could be the explanation. Meaning the patient does still have hypothyroidism, and in that instance, because it's opposite, then that means the patient has primary hypothyroidism, which is usually Hashimoto's thyroiditis. Did I answer your question?
Yes, thank you.
Okay. We're clear with the labs, right? Okay, and then we'll come back to this later when we get to hyperthyroidism. So here are the locations of the thyroid glands. We have, normally they're not palpable. They're so small that all you can palpate is you can palpate your trachea more than your thyroid glands. When they are enlarged though, they become very palpable. Now, the reason for the enlargement is really the same mechanism as how a penis enlarges. So how does a penis enlarge, Miss Decker? During an erection.
Vasodilation?
Okay, because there is vasodilation and there is increased blood supply, correct? This is the same example here, exact mechanism. So what causes the thyroid gland to enlarge is really the increased blood supply to it. So the more blood flow it receives, then the bigger the thyroid gland becomes. So later, when we get to thyroid surgery, the aim is, because is it safe to do surgery in this state wherein you have very large blood vessels causing the enlargement or the increased blood flow to the thyroid gland? Is it safe to perform surgery at that state?
No.
No, there will be massive bleeding. So before surgery, later, the patient will have to be receiving medications first to suppress the activity of the thyroid gland. We want to shrink it first before we can remove it. All right. So in the, by the way, goiter is present in both hypothyroidism and also in hyperthyroidism. In the case of hypothyroidism, why it enlarges is not because of the hyperactivity, because it is incapable of producing T3, T4. Therefore, the cause of the goiter in hypothyroidism is really the high TSH. The more the TSH is released, then the more stimulation, the more the activity there is in the thyroid gland. But however, no matter how you stimulate this thing, no matter how big it gets, it just cannot produce T3, T4. Okay, there's a problem with the thyroid gland. So T3, T4 are your primary hormones that control metabolism. Every cell in the body depends on T3, T4 for cellular activity. So therefore, if you have hypothyroidism, your metabolic rate drops significantly. So it would only make sense that when you're in a hypometabolic state, so you'll have decrease in everything. No energy, you're sleepy all the time, you cannot tolerate cold temperatures, no appetite, but yet you gain weight despite not eating enough. This is due to the really slow metabolism. Right? You eat a little bit, then that could probably sustain you for the whole 24 hours because your cells are just not working correctly. So this will, imagine this happening with every cell now to your heart, for instance, your lungs, your brain, right? Every single cell in your body, your GI tract, okay, everything slows down. So your attention span is slow. Your thinking is also slow. You're slow to respond, slow to speak, slow in everything. So blood pressure drops, heart rate drops. Okay. So here, so you'll have decreased cardiac output. So patient has hypotension. Patient has, it could develop cardiac enlargement because now you have congestion of blood in the heart now. So this can really lead to heart failure as well. As skin changes, there's lack of sweating because even your sweat glands are have hypoactivity. low metabolic rate. Therefore, not enough sweating. Your oil glands also are slow. So not enough oil to lubricate your skin, so your skin becomes dry, coarse, and hair becomes thin and fragile. This is hair everywhere, from your head and also your body hair, pubic hair, everything will be low. And then it'll be faster later. So when we get to hyperthyroidism, we simply put everything in reverse. So if you have a really slow metabolism in hypothyroidism, it'll be the complete opposite when we get to hyperthyroidism. So you have low T3, T4. Your metabolic activity is low. So how do we treat this patient? Thank you, Miss Corbin.
You would have to put them on a medication that suppresses the release of the T3 and T4.
What was the verb you used again? To do what?
Suppresses.
Well, we're already low, so what do we?
Oh, this is for low. I thought you said for hyperthyroidism. Okay, so then you do replacement therapy for that.
Okay, very good. So there's only one drug, levothyroxine, different brands, but basically it's levothyroxine. Now, this is not a drug that will stimulate T3, T4 production, okay? This is T3, right? So levothyroxine is the triiodothyronine. So it's ready for use. So that's why the instruction here, that's why we take it early in the morning, first thing in the morning, because it will mimic the natural release of level of T3, T4 by the thyroid glands. So we try to mimic the same process. So the instruction is take it as soon as you wake up. So same thing in the hospital, in the nursing homes, okay? I forgot to mention the diagnostic test. So as the example given by Yan, for instance, so these will be the three that will be drawn constantly. So in hypothyroidism, what are the levels of the T3, T4? In primary hypothyroidism, T3, T4 will be Miss Vivian.
Will be decreased.
Okay, what about your TSH in primary hypothyroidism?
Increase.
Very good, it'll be opposite. What about in secondary hypothyroidism? What will be your TSH level?
Will increase.
In secondary?
Decrease, increase is gonna be the opposite. Yeah.
No, it'll be the opposite in primary. T3, T4 low, high TSH in primary. What about in secondary? Remember, secondary is a pituitary problem.
All low.
Okay, all will be low.
Low. Okay.
All right. So how do we give the levothyroxine? All right, because this thing affects cardiac function, it is very important to start it slow because we don't want to overwhelm the heart. That's why you have your safety alert here. Thank you for reading, Mr. Richard.
In patients with a history of cardiovascular disease, the increase in dosage of levothyroxine are made cautiously because sudden increase in cardiac rates and contractility secondary to the medication may lead to angina or congestive heart failure.
Okay, thank you, sir. So you'll see it's not uncommon for, let's say, a patient comes into the hospital diagnosed for the first time with heart disease. One of the diagnostic tests they'll draw is T3, T4, and TSH level. So actually, it's a complete thyroid panel. So the doctor will order a thyroid panel because it's possible that It may not be a heart problem. It may be a pituitary problem causing the cardiovascular disease. Does that make sense? Complications will be, think of a really severe form of hypothyroidism, okay, which is called now mixed edema coma. So imagine the signs and symptoms we talked about earlier, and then making them really extreme, like really extreme bradycardia, really extreme low blood pressure, really extreme mental activity, right? GI activity, everything is low. So what will that patient look like? Will they even be conscious? Will they be alert and oriented? Not with enough, not without enough blood and oxygen to the brain, right? So the patient here will be unconscious already. They go into coma. That's why the term is called mixed edema coma. However, the coma here is more of a late sign. The patient usually dies from the other problems first before they die from or they develop coma. Because respiratory rate here drops, so therefore that's why you have low oxygen and high CO2. And then there is now low kidney output also because there's less blood getting to the kidney, so you'll have oliguria, and so therefore the patient may go into kidney failure here. The patient also, because your GI activity is also low, that includes the pancreas, okay, and then you also have less cellular activity, so you cannot generate enough. Even your adrenal glands here are also slow, so your cortisol levels will also be slow, leading to hypoglycemia and hyponatremia, because the same adrenal glands will also not be able to release enough aldosterone, okay, in order to reabsorb sodium and water. And here's a safety alert. Because of the nature of the slow activity, be careful with whatever you're giving these patients, especially CNS depressants, namely sedatives, hypnotics, or narcotics, right? So be careful with these medications because it may lead to mixed edema, okay, without you knowing it. So the doses when giving these drugs must be considerably lower than for normal clients. It will require dose adjustment as well as the frequency as well. They shouldn't be given normal doses because their metabolism is considerably low. So let's summarize. So these are your signs and symptoms affecting all the body systems. Then don't forget about the goiter. Again, the goiter here is due to the high levels of TSH, not a hyperactivity of the thyroid gland, because obviously they have the opposite. And I'll let you read the rest. A common teaching here for patients in order for them to monitor whether or not their hormone needs are being met, because Miss Omo, is your metabolic needs the same all throughout your life?
No. As you get older, it changes.
Okay, so age changes. So what happens as you age?
Your metabolic needs, they get less.
All right, so you have less metabolic activity, therefore your metabolic needs also drop.
Yeah.
Let's not talk about aging. Let's just talk about now. So between week 1 and week 15, will your metabolic needs remain the same from May to August?
Not
You asking
necessarily.
me?
Oh.
Yes.
It depends, I guess.
Okay, depends on what?
Maybe the medications you're taking.
Okay, let me be more specific. So
The
this,
activity also.
yeah,
Like,
today is week 5, right? And then compare this to week 1. What happened to your metabolic activity between week 1 and now week 5? Is it the same?
no, can it like fluctuate based off of what you're doing?
All right, stress levels will change your metabolic needs, correct?
Yeah, stress, even like exercise, anything, right?
Yes, everything. So let's say Miss Janessa, if you become pregnant, will your metabolic needs remain the same?
No, it would change because you have releasing hormones and different things happen into your body.
All right, so therefore, can we stay with one dose throughout this patient's life who has hypothyroidism? Can we give them one dose and then that's it? See you later.
No, it has to be
No.
checked.
Right. There has to be regular checkups every few months. Your T3, T4, and TSH level have to be checked constantly because your metabolic needs differ, stages in life, stages in nursing. Okay, so from first semester all the way to this is now your 4th semester. So you have metabolic um, rate changes there, okay, depending on where you are in school or the semester, they will constantly change. Two very practical examples here for the patient to know whether or not they need to go see their doctor are based on their sleep activity and their bowel movement. So very two common things we usually teach the patient is if you notice that you've been sleeping more than usual or you're getting more constipated lately, what happened to their hormone needs? Did it increase or decrease?
It's gonna decrease
Their hormone needs.
activity.
It's gonna be increased. The hormones is going to be increased.
Okay, meaning if you're sleeping more than usual and you're getting more constipated, that means are you getting enough hormones?
If you
I
sleep,
don't
No.
think so. I think they're gonna get less hormone because they don't really move.
No. The patient has hypothyroidism. Okay, they're taking the hormones supplements every day. How will they know whether they're getting enough? So again, my teaching is based on their bowel movements and their sleeping pattern. So if they notice that they're sleeping more than usual and they are getting more constipated, what happens to their hormone levels? Are they getting enough or too much hormones?
They're not getting enough hormone.
Okay, so therefore, because those two are symptoms of what? Hypothyroidism or hyperthyroidism? The constipation and the...
Hypo.
Okay, so those are simple things you can teach your patient because they have to, they're home. Okay, they're just taking the pills, but they can tell that the hormones they're taking are not enough if they're sleeping more than usual and getting more constipated. And then vice versa. What if they have they're hypothyroid and then they're taking the hormone, but then they're getting more diarrhea and they're having insomnia? What do they have?
Hyper. Too much.
Hyper, and they get too much.
All right, very good. So that's why this is what I'm talking about. You should teach the patient signs and symptoms of both because it's a delicate balance with these hormones. Okay, you take them every day doesn't mean you stay with one dose. There will be changes, right, throughout their life. So therefore, it's important to monitor for both signs, because the patient could have hypothyroidism, meaning we're taking too little, we're not taking enough of the hormone, or certain changes in life may cause us to have a higher dose, although the dose never stayed the same, but our metabolic needs change constantly. So it's important for the patient to be aware of what's happening. Any question before I go to hyperthyroidism?
Professor, quick question. Let's say the patient take the Synthroid not first thing in the morning. Would that reduce the effect of the medication?
Yes. Let's say they don't take it early in the morning, they take it later in the day. So that will change their sleeping pattern now, because the natural release of T3, T4 is they're higher in the morning. They start in the morning and then peaks around noontime. So the levels of your T3, T4 peaks around noon and then slowly and gradually drops toward the evening and then lowest at night. So therefore, if you take it too late, what will happen to your activity level at night? Are you able to sleep?
No.
No, that will change your sleeping pattern. Okay, so it's important that patients understand this, right? So that they understand, ma'am, sir, your thyroid glands are not working anymore. So that's why you take these hormones. These are the replacements. Okay, you take these for life. Then you teach them all the bells and whistles on how to manage the disorder. Especially with when to take the thyroid hormones. Okay, and then what the signs and symptoms, very important for them to know, are these here. Signs and symptoms of hypo, meaning they're not getting enough hormones, or hyperthyroidism, they're getting too much. And then again, this is a constant balance they have to be aware of every day, and then they notify the physician. And then very important is to meet the doctor, regular appointments, so they should not miss them. Any other question before we go with hyper?
Does hypothyroidism affect the parathyroid?
No, they're separate. So when we get parathyroid problems, they will have separate causes, separate signs and symptoms.
Okay.
Yeah, because they have completely, again, I started with the function of the thyroid and the parathyroid, right? So the glands, their function is number one, T3, T4, to control the metabolic activity of the body. And then the third hormone was calcitonin, which is going to lower the calcium levels. The parathyroid hormones only have one job, which is to raise the calcium levels by releasing parathyroid hormone. If there's no need for that, then the parathyroid glands have an easy job, right? Which is nothing. If your calcium levels from your metabolic activity changes, so there will be changes in our calcium levels, could be high or low. So that's where your parathyroid hormones come in. Any other question? Alrighty, let's go to hyperthyroidism now. So this is the complete opposite. The ages are the same with hypo and hyper. They affect women of childbearing age, 20 and 40. In hyperthyroidism, there's also a primary and a secondary. We looked at it under hypothyroidism. I won't go back there again. As far as the causes though, if it was Hashimoto's thyroiditis in hypothyroidism, it's called Graves' disease hyperthyroidism. So this is the most common cause. Again, same as Hashimoto's thyroiditis, we have autoimmune disorder here. So the problem in hyperthyroidism is the complete opposite of hypo, wherein In hypothyroidism, you had hypotension, bradycardia, decreased mental status, decreased GI motility. Everything was slow, correct? I mean, the patient had low appetite, but then they were gaining weight. There was hair loss, right? There was also, we didn't do the sexual activity, because after all, this is 20 and 40 years of age. So the libido in hypothyroidism was low, so there will be opposite here. So in hyperthyroidism, look at your manifestations now. Everything's high. Heart rate, blood pressure, high. They're so high that they will also cause dysrhythmias. Even hypothyroidism. In Hashimoto's, the patient had bradycardia, right? Which could be sinus bradycardia, if it's sinus, or patient may have heart blocks as well. There's thyroid brewery because of the increased blood flow, like I described earlier. So the goiter here is due to the hyperactivity of the thyroid gland. They have heat intolerance instead of cold. So there'll be diarrhea here, loose stools constantly. Despite the increased appetite and the increased food intake here, which is common in hyperthyroidism, they continue to lose weight. Meaning, no matter how fast they eat, it's impossible to eat every minute, every second of your life, right? You have to do something else. So they cannot replace the amount of calories that they're burning. They will constantly be in a negative nitrogen balance here, because again, the patient has to stop eating at some point, but then their metabolic activity is so fast that they're just burning through their own body. Okay, they're eating themselves up because there's not enough food intake here. Okay, the metabolic activity is so fast. And because you're burning through energy, there will be fatigue eventually. There's jittery, the patient's restless, so therefore they're nervous as well. They can't sleep. There will be menstrual changes as well, and as well as hair loss, the same as with hypothyroidism. Another key feature here is the exophthalmos. The patient will have a startled eye look because of the eyelid retraction. So here we have a normal eyelid. This one, the eyelid is missing. It has retracted into the eye socket. So giving the patient a startled eye look. It's not like their eye enlarged. Okay, it's not really like that. It's really the absence of the eyelid. And because of that, the patient's eyes will be prone to injury here because they can't completely close their eyes. So exposing the eyes to dryness, could have corneal abrasion, cracks on the lens. Okay, so we need to protect the eye. We'll discuss that later. So lab findings here in primary hyperthyroidism, what will be your T3, T4? Of course, high, but then you're in primary hyperthyroidism, the TSH is low. However, in secondary, the TSH will be high as well. The diagnostic test, the diagnostic test done here is using radioactive iodine. I think the name is RAI 123 because RAI 131 is used to treat hyperthyroidism. But for diagnostic purposes, they use RAI 123. How the test goes is the patient will be given the pill. It's radioactive. Now, since there's only one gland that uses iodine in the body, no other gland or organ, for that matter, uses iodine. It's only the thyroid glands. So therefore, they give the pill today, and then they take scans of the thyroid glands the next day. So they'll take the patient down to nuclear medicine, and then they take pictures. So if there's an increased uptake of radioactive iodine, then that means the thyroid glands are very hyperactive. The normal uptake is usually 30 to 50%. So if the uptake of the radioactive iodine is higher, then that means it corresponds with the activity of the thyroid glands. All right, how do we treat this? Before we can do surgery, there has to be pharmacologic treatment first. So for reasons I stated earlier, it will result in massive hemorrhage if we do surgery right away. So there will be pharmacologic first, and we can even try, depending really on the patient's state. So let's say the patient is pregnant, definitely we can't do radiation because that would be unsafe for both the patient and the baby, especially. So we can do pharmacologic interventions instead. And then the patient, though, in this case, will eventually need surgery. But until then, we control the patient's symptoms with medication. All right. Speaking of which, we have beta blockers.
Work.
Yes. Thank you. All right. Beta blockers. This has nothing to do with the thyroid gland, meaning the beta blockers won't treat the hyperthyroidism. However, it will help control the symptoms. Imagine the symptoms earlier. So if you're jittery all the time, you're shaking, you have these tremors, you're nervous all the time because of increased adrenergic activity, because your sympathetic hormones will be high here because of the hyperthyroidism. So to control that, the patient will need propranolol, or atenolol, but between the two, propranolol is the preferred beta blockers for hyperthyroidism. And then for long-term management, we have two choices here. We have PTU and methimazole. Both are thionamides. And a third drug will be lithium. Although between the three, PTU and methimazole are used more frequently because of the side effects of lithium. For surgical preparation, the patient will be given iodine preparations for about 2 weeks before the scheduled surgery. The purpose, because if you really think about it, one of the causes of hyperthyroidism is actually increased iodine intake. So people who have high seafood intake can potentially develop hyperthyroidism, or anyone else who are taking too much iodine in their diet. The reasoning behind giving iodine preparations is really based on, because this is supposed to cause hyperthyroidism, right? If you give the patient high doses of iodine. But the principle behind this is Israel. When was the last time you were at a buffet, sir? Before
probably like over 2 years ago, probably 2 years ago.
Okay. When you, how many trips did you take to the buffet table before you said, I've had enough?
Well, I usually probably 3, but I just get like 3 huge plates.
Okay.
So I don't have to make a lot of trips.
Yeah, because it's a buffet after all, right? I mean,
exactly.
Yeah, that's why we're there in the first place. Okay. So, if after the 3rd plate somebody offered you dessert and another plate, what will you say?
No, that I would say no. That usually be my 3rd plate, my fruits and stuff.
Okay. All right. So this is the same principle behind iodine preparations. So if you give the thyroid gland a lot of iodine at one time, what will it say?
It will reject it. It will say no, it's full.
No, I've had enough. There's too much. So therefore, what will happen to the activity of the thyroid gland if you give it too much iodine at one time?
It will become too active.
Right, it will suppress the activity because it will say no more, no more. I've had enough iodine. However, because it still has a potential to cause thyroid storm, which is the complication, meaning this is the opposite of myxedema, where in myxedema we had really exaggeration of the symptoms in hypothyroidism, right? So the same thing here. Patient could go into thyroid storm if you give this drug by itself. However, this is never given alone. It is always given with PTU or methimazole. Now, the action of these two drugs is to prevent iodine binding in the thyroid, meaning even if you give iodine to the patient, it cannot bind with the thyroid gland because you gave PTU and methimazole first. So if we're preparing the patient for surgery, we're giving all three. However, you must not give iodine ahead. You must give PTU or methimazole 1 hour before you give iodine preparations. The iodine preparation here is SSKI, saturated solution of potassium iodide. So it's not pure iodine, it's potassium iodide that they're giving. So the rule is you give PTU or methimazole first, 1 hour ahead, and then 1 hour later, you give the iodine preparation. Is that clear?
Yeah.
Okay.
Computer.
Yes, go to mama, please. Close the door. Thank you. Okay, and here's the rationale for giving steroids in thyroid storm. Steroids are only given in thyroid storm. Okay, we don't give it as part of the treatment for hyperthyroidism. So this is used only for thyroid storm. Okay, so what triggers thyroid storm in the first place? Which we forgot to mention in myxedema. All right, let's backtrack to myxedema. So a patient with hypothyroidism can develop myxedema due to stress. Stress can be anything. I mean, it could be physical, emotional, or environmental stress. The patient usually gets sick. And then when they get sick, do they take anything by mouth? Say they're vomiting, having diarrhea. Do you like to eat or take your pills for that matter?
You can't take anything if you're vomiting.
Right. So therefore, that could be one trigger wherein the patient stops taking their hormone. Therefore, they develop hypothyroidism. Or a patient may be out of insurance. They don't have financial ability to afford their hormones. Okay. Or maybe they just are non-compliant. Okay. Maybe you're dealing with a alcoholic or IV drug using hypothyroid patient. Okay, they stop taking their hormones and then they develop myxedema. So here, the same thing. Thyroid storm can be stimulated or triggered by stress. So stress again can be physical, psychological, or infection. Okay, those are all stressful events, and especially if this patient is going through surgery. So a hyperthyroid patient being prepared for surgery is stressful enough, right? And surgery itself is stressful. So therefore, that's why we give iodine preparations before surgery, okay, along with PTU and methimazole. So this is very important. So we give this to the patient about 2 weeks before the surgery. So all these here, PTU, methimazole, and the iodine prep, will be enough to decrease blood flow to the thyroid, therefore decreasing its size, decreasing blood flow, decreasing the possibility of bleeding during surgery. To combat thyroid storm also, by the way, the thyroid storm is also a emergency, just like hypothyroidism or mixed edema, sorry. The two key manifestations of thyroid storm here is a rise in temperature. So you have tachycardia, fever, and systolic hypertension. So these are the three main signs that the patient is going into thyroid storm. So if the patient, especially pre-op, this is when this thing could occur potentially, or even during surgery as well. Patient may go into thyroid storm during surgery. So watch for these signs. Again, our prevention for this are these drugs here. Okay, and then of course, early recognition of thyroid storm. Thyroid storm is managed by the same medications. It is nothing special. We give these as well as the, where's the beta blocker? Right here. Okay, so we give the same medications because there's really nothing else. We just give them in higher doses. Oh, along with glucocorticoids. And the rest of the management are symptomatic. Say the patient will have a high temperature, right? The fever here can be high, so we give them cooling blankets. However, the patient could potentially die from cardiac dysrhythmias that could resolve during the crisis. So these are your other interventions. Any questions before I proceed? All right, let's go to table 43.3. So these are now your nursing responsibilities for each of the drugs. The testable part here are these. Okay, it's always the nursing implications. So here are the actions which I mentioned earlier. So both of these drugs pretty much block iodine binding in the thyroid gland. So about the same instructions here. Oh, well, they're both thionamides after all, so that's why they'll have the same side effects, the same nursing interventions. Lithium is different. And you have, here's the iodine. It is iodine, so you learned in fundamentals of nursing that you give it through a straw, right? Because this will stain the teeth. And these are other unpleasant side effects related to the drug. Let's go now to surgery. So before the patient gets surgery, okay, before the patient can get surgery, we have to give these drugs first to shrink the thyroid. So once the doctor determines that the patient is in a normal thyroid function now, then we can do surgery. There's two types here. We can do the total, meaning we'll remove the entire thyroid gland, or we can do subtotal or partial. Now, post-op management will depend if we either took the whole thing out or only a portion of it. So of course, if there's a remaining thyroid gland, the patient won't necessarily develop hypothyroidism because there's still a gland remaining. So therefore, the patient will probably be taking levothyroxine for maybe 1 to 2 years. And then after that, the remaining thyroid glands should compensate for the patient's metabolic needs, and therefore not necessarily need or require thyroid hormone replacement for life. However, for total thyroidectomy, then of course there's no thyroid gland left, then the patient will have to be taking levothyroxine forever. Another post-op complication is because the parathyroid glands are attached to the thyroid glands, so therefore it will result to either injury or the removal also of the parathyroid glands because they're stuck to the thyroid glands. That's where they're located. So potentially when you remove the thyroid, you may also remove the parathyroid gland, resulting in hypoparathyroidism. So therefore, I said earlier that the one job of the parathyroid hormones is to increase calcium levels. So therefore, if they're gone, the patient will have what problem? Miss Jordana?
No.
Hypocalcemia.
Hypocalcemia. Other damage are to the laryngeal nerve because the incision is right on your neck. Horizontal incision, like you're slitting the patient's throat, literally. Well, not literally, because we don't reach the throat. But the neck incision is very close to the airway, so therefore there could be damage to the laryngeal nerve, which runs through there, as well as problem swallowing. And it could also potentially obstruct the airway if we're not monitoring them. Which is the next topic, monitor for airway compromise. Hemorrhage is possible, although we took care before surgery to make sure that doesn't happen, but it could potentially still happen. Hypocalcemia because of the parathyroid damage. This is a common post-op activity, and any textbook will say the same thing. You always check for bleeding, not only in the dressing itself, but on the back of the neck, because the patient's position post-op will be Fowler's. Therefore, by gravity, blood will always drain toward the back, following gravity. So you won't see the blood on the dressing itself. Sandbags will be used just to maintain a neutral head alignment. We don't want hyperextension, definitely no hyperextension, because that will put strain on the incision and may cause bleeding. The problem there is the incision is fresh, the bleeding may not come outside, the bleeding might go inside, and therefore could, although there's no surgical incision on the airway, but it could cause enough pressure around there, meaning the hematoma will cause a buildup of pressure around your neck and then therefore may obstruct your airway. So here's the position, semi-Fowler's or higher. Again, this will serve two purposes, better breathing as well as prevents aspiration. Hypocalcemia is monitored for what are the two signs of tetany again? What were those two signs, Miss Davian? That tells you calcium levels are low.
You have the taste switch. I forget what it's called. The Chevostic sign.
Chevostic, right?
Chevostic sign, yes. And I'm not sure what the second one is.
Starts with a T.
Is it the tetany?
The Trousseau sign.
Trousseau, okay,
Trousseau, okay, yes, that's it, okay.
So Trousseau is the carpopedal spasm of the hands and wrist when you apply pressure or tourniquet to the upper arm. The tourniquet there is, of course, the blood pressure cuff, right? And then for the Chavostics, you simply stroke either side of the patient's cheek and you observe for twitching of the mouth and the face. Because of the airway compromise, another thing you should prepare for is intubation equipment, or if necessary, a tracheostomy tray. Because two things can happen here. So patient develops airway compromise, right? However, if you're having laryngospasm at the same time, that will narrow your airway. It may not be possible to put in the laryngoscope. So therefore, if the intubation is not possible, then you do tracheostomy. So that's at the bedside. So these are the equipment you need to maintain at the bedside: suctioning, oxygen, tracheostomy tray, and the intubation equipment, which is in the crash cart for the first 48 hours. And here's the summary. And I'll let you read the details on the nursing care. Again, as we did in the patient for hypothyroidism, we taught them. So in this instance, the patient now, let's say the patient had total thyroidectomy. What does the patient have now?
Hypothyroidism.
The patient now has hypothyroidism. So we're back to the hypothyroidism management. So this part here is still part of hyperthyroidism, okay? This is not a continuation of the post-op. So post-op stopped there, but remember the patient now developed hypothyroidism after surgery in the case of total thyroidectomy. So these activities here, these nursing care here is referring to obviously before surgery. Here, you're still giving antithyroid medications, iodine preps, the beta blockers, cooling measures, and eye care. Right? We can do artificial tears here to lubricate the eyes, and at night, because they can't completely close their eyelids, so we can do we can tape it gently or use eye patches, or if you want you can staple the eyelid shut. Okay, so watch for thyroid storm. They should be aware the earliest indicator of a thyroid storm is a rise in temperature, even just 1 degree. Speaking of which, so the patient is pre-op. They're still on the floor. To prevent thyroid storm, where would you put the patient? What room will be best for the patient? Because remember, thyroid storm can be triggered by stress. Stress is a very broad term. Is it stressful when there's noise around you?
No.
Yeah. Is it stressful if
Oh yeah, yes, it's just
somebody annoys you?
yes.
Is it stressful with the thought of you're having surgery in the morning?
Yeah.
Yeah, or like thought of having a test in the morning.
Okay. So the very fact that the patient is hospitalized is stressful enough. So we don't want additional stressful triggers. So therefore we keep the room quiet. We keep the room dim. No unnecessary disturbances. So will the room near the nurse's station be the best place for this patient?
No.
No. The nurse's station is the noisiest place on earth. There's gossip going on there. There's monitors going off. There's phones ringing. Nurses gossiping, which is the why we go to work every day, to hear the gossip. There's conversations there. There's what else do you do at the station, Miss Omo? Since you work in healthcare. Besides gossip, what else? What else? What other fun things happens at the nurse's station?
Besides gossip.
Besides gossip.
Well, people like to give each other advice on how to care for the patients. I don't know.
I thought you couldn't think of any because you may be thinking, oh, what could be better than gossip?
Yeah, it's not bad. What I have is not bad. That's a good thing. People
Yeah.
do that a lot where I work. They help each other out, give each other tips.
On top of gossip, right?
On top of gossip, yeah.
That's it. Any questions on hypo and hyperthyroidism? I'll cover parathyroid disorders next week. So let me stop the recording.